Hello, good evening, good afternoon, good morning from wherever you're joining us from. My name is Juliet Ouma. I am the Programs Assistant at African Pharmaceutical Network, and it's a delight to have each and every one of you join us at a time such as this. We apologize, we are 5 minutes late, but we are here for a great purpose, and we are hoping that we'll be able to accomplish it. And we are all going to be delighted that we made the choice of joining this session this afternoon. So with that, I would like to present my screen. Then I will go through a few housekeeping rules, and then we will get this show on the road. So as you may have noticed, your microphone and your cameras are off, and this is for the purpose to avoid distraction. But during the Q&A session, if you'd like to voice your question or to share a comment with us, you are requested to raise your hand. We will unmute your mic and also enable you to be able to switch on your camera. Then you can voice your question or share your comment. Secondly, please feel free to share on the chat. Let us know who you are, where you're joining us from this afternoon. And lastly, please feel free to use the Q&A box to share your questions during the webinar and even afterwards, and we will have our speakers who are going to take your questions. So our industry discussion forum this afternoon is on curbing the burden of antimicrobial resistance through education and public sensitization. This being the World AMR Awareness Week 2024, we are glad to be participating in this global health campaign. And in any way that you are able to participate, be it through posters, sharing comments online, inviting your friends, and just creating awareness about AMR, please do so. Because this is a challenge that is not only for us as healthcare workers or those who are working within healthcare organizations, but this is a challenge that directly affects our communities. It could be an auntie or an uncle or a grandparent who could actually find themselves in a situation where they are dealing with a drug-resistant bacteria or microorganism. So with that, I will quickly take us through the work that we do as African Pharmaceutical Network and who we are as an organization. So African Pharmaceutical Network was established in 2020 amidst the COVID-19 pandemic, and it was established with a desire to address the challenges that we face within Africa's pharmaceutical sector and within our healthcare systems in the African industry. Therefore, Africa Pharmaceutical Network was established as a networking organization that brings together professionals, stakeholders, and organizations working within Africa's pharmaceutical sector for the purpose of knowledge sharing, policy shaping, innovation nurturing partnerships towards a robust pharmaceutical sector anchored on reliable access to safe, efficacious, affordable quality medicines and pharmaceutical services to the African people. This is because we also agree and we know that the health industry in itself, we need to have access to reliable access to safe, efficacious, and affordable quality medicines for our people. Already as a continent, we totally rely, we do rely on 70 to 80% of imported drugs and pharmaceutical equipments. Therefore, our idea is to change this narrative. Is there a way that we can share knowledge? There is knowledge that is working within the southern part of Africa. Can the eastern part of Africa actually leverage this knowledge to find solutions to their problems? Through policy shaping, through partnerships, can we come together and work together towards a common goal? Therefore, we can change the narrative of Africa. So our background leading towards the establishment of our organization was limited local pharmaceutical manufacturing capacity in the continent. As I have said, 70 to 80%, that is a large number. There are many other countries within the continent that are actually pushing for local manufacturing. But what I can ask you this afternoon, how is your country participating in local manufacturing? Is it that in each and every instance, we will be quoting South Africa? Is it that in every instance, we'll be quoting Morocco and Egypt? But right now, I am so glad that in Rwanda, that BioNTech actually did set up an mRNA vaccine facility in Rwanda. So Rwanda is also participating. How is Kenya participating within East Africa? How is any other country participating within their economic regions? So we have to come together and leverage the capacities and the resources that we have so that we can boost local manufacturing within Africa. Another reason was segregated continental pharmaceutical industry operations. And what I ask myself each and every time, how many times or how often Do pharmaceutical supply chain professionals, how are they acquainted with regulatory policies? Is it that most of the times you sit down and you say, hey, I am a QA pharmacist, I am a supply chain pharmacist, so I wouldn't really care about regulatory affairs? Ask yourself, do we work in silos? And how is it profiting for us to work in silos? Is there a way that we can come together and be sure that we can leverage the resources that we have so that as we come together, we use what we have towards a common goal? So ask yourself, has it been profiting so far, and how can we change this narrative? Another incident that also led to the establishment of African Pharmaceutical Network, there is a lack of a common platform to drive industry-led continental agendas. Therefore, APN was established as a network that brings together professionals and organizations within the pharma industry. We are the ones working within the industry. We are the ones who know the challenges that are within the industry, and the solutions are also with us. But oftentimes we lack those platforms where we can come together and drive for the agendas that will better us as Africa's pharmaceutical sector. Therefore, when we have a platform such as this, therefore I know I can come together with professionals who are working in Rwanda. I can come together with professionals who are working in the northern part of Africa, and therefore we can drive an agenda that is actually profiting for the continent as a whole, not just for one specific economic region, but for the continent as a whole. So what is our aim as APN? To foster continental knowledge sharing, workforce development within the pharmaceutical industry. When we share knowledge, you share best practices. Knowledge is power. Without that kind of knowledge, then there is no way that we will say that we are going to be driving the agenda of the industry. There is no way that we can say that we are going to lead reliable access to safe and quality medicines, because some of the problems that we have, the solutions have already been found in other sectors. But if you can come together and share this knowledge and empower our pharmaceutical workforce, then we can be able to do an amazing thing for the continent. Our aim also is to promote best practices and stimulate innovative models of service delivery within the pharmaceutical industry. How best can you work as a professional? What are the practices that you have? Do you adhere to good standards of practice? How do your patients feel once they come into your hospital, into your clinic? What kind of deliveries do you use? What is the kind of service that they are going to get? You are the industry. The industry is who we are. So if we do not have good practices, we do not have good service delivery, then we are the ones who are failing our own pharmaceutical industry. Then our aim also is to champion for responsive, market-driven policies and regulatory frameworks within Africa's pharmaceutical industry. And lastly, to stimulate investments within the African pharmaceutical industry. Africa as a continent is a place of great opportunities, a place where investors can come and invest for good, not for evil. But what we ask ourselves, the policies that we have as a continent in different countries, do these policies actually champion for investments? Do these policies actually allow for investors to come within our continent, within the different countries, and be able to invest? And when they invest in our economies, is it an advantage for us or an advantage for them only? It should be an advantage for us because this is our continent. Lastly, I want to take us through our priorities. Our priorities are pharmaceutical workforce development, business ecosystem support, and policy shaping. And this afternoon, our focus is greatly on pharmaceutical workforce development. As a professional, what is the risk of AMR when it comes to your work? What are the pains of AMR when it comes to the life of your patients? What are the pains of AMR when it comes to new antibiotics, when it comes to the current antibiotics? Therefore, what we bring, we say we need a workforce that is well equipped, a workforce that is skilled, a workforce that is empowered to handle the challenges that are within the industry and to do the work that is there within the industry. Our how? It is through industry discussion forums, such as the one that we are having right now. It is going to be a knowledge sharing session. It is going to be a session where we are going to be empowered so that we can take what we receive from here and go and make a change in our communities. We also do this through training and experiential learning opportunities. We have a pharmacy academy, and I will take us through that shortly. Through policy advocacy and environment shaping. We also do this through market intelligence and technical support to stakeholders. As a manufacturer, when you manufacture your medicine, how will you bring it into the market? there is a regulatory process that needs to be followed. In different countries, you will have to follow a regulatory process. You will require someone to do a market research for you. You will require someone to help you with the regulatory services, the pharmacovigilance services. These are the kinds of support that we offer to our stakeholders from time to time. Our team, we have an advisory board team made up of 3 advisory members. We have McDonald Nwose, who is a board member, Kirti Nasai, she works with Chemonics, based in South Africa. We have Dr. John Paul Omolo, who is also a board member. Our secretariat team is made up of Dr. Lucy Machocho, technical programs assistant, myself, and we also have Thomas Ogola, who is not included. Our leadership team is under the able hands of Dr. Odhiambo David, our curator, Dr. Kelvin Odongo, Director of Operations, Dr. Esther Anyango, Director of Research and Knowledge Management, Dr. Denish Kineni, the lead PV trainer, and Dr. Anushri Patel, the lead trainer for regulatory affairs. These are our partners whom we have been able to interact with since 2020 until this moment. Our geographical footprint is currently in 24 different countries and some even outside Africa. So as we are continuing to expand our footprint, we also encourage you to be part of the work that we are doing as APN, and then we will get to see what is it that we can offer Africa and the world at most. Our offerings, we have the pharmaceutical workforce development. I have spoken about this, and how we get to achieve this. It is through trainings, workshops, and industry discussion forums. We have 3 main courses currently in our pharmacy academy. We have the regulatory affairs training, the pharmaceutical supply chain management training, and the pharmacovigilance and patient safety training. Please feel free to engage with us. You can train under the pharmacy academy with us for these 3 courses, and we will be rolling out 2 more courses come the year 2025, and we'll be glad to train you on the courses that we'll be having under the Pharmacy Academy. So with that, what next for you? You can become a member of African Pharmaceutical Network. You can partner with us on different projects that we have, or even on projects that you have. We can be there to help you and assist you in the various ways that we have within our capacities. And then you can also learn with us under our Pharmacy Academy. So with that, thank you very much, and that is African Pharmaceutical Network. Now coming to this session, we are going to be interacting and discussing about antimicrobial awareness. And this is basically mostly a sensitization moment. And we have guest speakers for you from Rwanda. And then we also have a guest speaker for you, Dr. Mevin Shahada. She's a pharmacist and she's working within Kilifi. And I would like to read their bios even as they get to interact with us this afternoon and share with us what they have prepared for us. So for this session, I will start by reading the bios, and I will read Dr. Mevin's bio. Then I will also read Dr. Marcel's biography, and then we will get into the session. So who is Marcel Ishimwe? Marcel Ishimwe is the founder and executive director of AMR Initiative Rwanda, a youth-led organization dedicated to combating AMR in Rwanda. Marcel is an IREX research champion, a One Health activist with leadership skills from Aspire Institute, founded at Harvard University and currently studying pharmacy at the University of Rwanda. He is an Eco-Climate Vision Ambassador in Rwanda and head of Environmental Health Department at Rwanda One Health and Innovation Club. Marcel was a guest speaker at the 2024 World AMR Congress and Disease Prevention and Control Summit, where he has presented on advancing antibiotic research through interdisciplinary collaboration. Very wonderful. Then we have Dr. Mevin Shahada. Who is Dr. Mevin Shahada? Dr. Shahada Mevin is a pharmacist at Kilifi County Referral Hospital and a committed member of the Antimicrobial Stewardship Committee, where she has dedicated nearly 2 years to advancing efforts to combat antimicrobial resistance. A strong advocate for diagnostic stewardship, Mevin actively promotes its integration into patient care, enhancing targeted treatment by training healthcare workers on diagnostic stewardship. This commitment reflects the 2024 AMR Awareness Week theme, Educate, Advocate, and Act Now. As a recipient of the Commonwealth Pharmacist Association's Africa Leadership Fellowship Antimicrobial Stewardship, Shahada has developed skills in AMS leadership, shaping her ability to promote sustainable antimicrobial practices within the hospital and across Kilifi County. Dr. Shahada continues to be an impactful educator and advocate of evidence-based healthcare through her work in AMS and diagnostic stewardship. And with that, I would like to welcome Dr. Shahada Mevin to take us through this session as you enlighten us. Welcome, Daktari.
Thank you so much for that introduction. So, yes. So my name once again is Mevin Shahada. I'm a pharmacist at Kilifi County Referral Hospital. And I'm also a member of the Antimicrobial Stewardship Committee. And I have a lot of passion in antimicrobial stewardship and infectious disease in general. So today I'll be taking you through antimicrobial resistance, antimicrobial stewardship practices that can be used to help reduce antimicrobial resistance. So basically our outline will be antimicrobial resistance and introduction, because we need to go back to the basics before we even understand what antimicrobial stewardship is. And then we will talk about a little bit about the burden and impact of antimicrobial resistance. And then we'll mention a little bit on diagnostic stewardship and talk more about the intervention, the antimicrobial stewardship intervention. Yes, so I'm hoping by the end of this training, you'll be able to perform at least one or two interventions. So before we even move to the next slide, I would like anyone to just type in the chat what comes to mind when they hear about antimicrobial resistance. So keep, as we continue talking, just keep typing what comes to your mind when you just hear when you hear someone mention antimicrobial resistance. So yeah, let's first start by looking at the antibiotics and the power of antibiotics, because before we started talking about antimicrobial resistance, we started by looking at manufacturing antibiotics, because initially they were not there and there are a lot of deaths, and then we went to, they were manufactured, and then it led to some reduction in the number of deaths. So with the invention of antibiotics, we can see that the number of deaths have they reduced remarkably. Like when you look at the pneumonia, both community and hospital acquired, the likes of heart infection and brain infection, even brain infection you can see, and yeah, brain infection you can see about 60% reduction in the deaths. Could you move to the next? Yes. So, and when you look at these, we started by manufacturing, like among the first one, the likes of penicillins, sulfonamides, and as we went by, more medications came in, like the streptomycin and chloramphenicals and tetracycline. And as we produce more antibiotics, the more we produce, the less the number of deaths that we are seeing in population. Next, could you zoom this in a little bit? Yeah. So let's also look at the timeline of resistant development to these antibiotics. We started by penicillin, and as you can see from that orange line, around 20 years later, we have started seeing antimicrobial resistance. Same thing to the tetracycline, the erythromycins. You do see some the development of resistance few years after its development. So, but on the very right side, you also see some of the data and the deaths attributable to antimicrobial resistance. Yeah, right. Could you move to the next slide? Yeah, so what is antimicrobial resistance? So let's just, before we delve into the definition, these are some of the things that we've been hearing, I'm sure, from people mentioning. One of the most common thing you will hear when you hear about resistance is MRSA. If you've not heard of anything, I'm sure you might have heard of MRSA. And MRSA is one of the resistant. MRSA is one of the resistant. Uh, it's one of the genes that microbes would develop that would lead to resistant. Even ESBL, and I'm sure more recently we've heard about the resistance of quinolones and third generation cephalosporin to gonorrhea. We've also, something very close to mind, we've also heard of multi-drug resistant TB, where we stopped using our first line, the RSVD, and we go to the second or third line even sometime. Some form of resistance have also been shown in P. falciparum, malaria, and also antiretroviral therapy resistance have also been seen, because we would start patients with on first line, and then when you look at their response, if they're not responding well and they keep having a very high viral load, you would start suspecting resistance there and then. So across the period, you've seen resistant to antibiotics, resistant to uh, antiparasites, and resistant to antiretroviral therapy. Yeah, next slide. So when we talk about antimicrobial resistance, what do we mean? Um, it's basically the presence of resistant genotypes or even phenotypes in the microorganism to antimicrobials, but it's set by something called selective pressure. So as you look at this diagram, we have introduced antibiotics. They have been able to target those susceptible microbes or bacteria, but they left two resistant bacteria. And once they left this bacteria, they were able to have enough room to grow and multiply, and kept multiplying until we regain these many resistant bacteria. And this is when a patient would come, and then you take a sample for microbiology for culture and sensitivity. You take it to the lab, they test it, and it comes out as resistant. So selective pressure, and under selective pressure, these bacteria, the susceptible bacteria, are killed, and the bacteria that are resistant survive, and they multiply, as we are seeing in this diagram. Next slide. So WHO this year released the uh, their list of priority pathogens for manufacturing, because as we go down the years, we have seen that we keep gaining resistance, but manufacturing has stopped for these antibiotics. So these are some of the the priority pathogens according to WHO. They have been grouped according to critical, high group, and medium group. And the criticals, these are things like because most of the hospital, I'm sure we do not even stock, as public hospital, they do not yet stock colistin. Most public hospitals, even county referral hospital, the drugs that they stock most of their last resort is carbapenem. And right now we are seeing carbapenem resistant enterobacterials. Enterobacterials are microorganisms like Escherichia coli, and E. coli is an organism that can cause a simple infection like urinary tract infection. So imagine someone coming with a UTI, and you're not able to manage because of resistant, and you do not, the only medication you have as your facility is a carbapenem, and you need a colistin, which you might not have. Yeah. So a couple of bacteria have also gained resistant to third generation cephalosporin, and this is the same. This is what you mostly call as ESBL group, and your the most common medication that will be used here is carbapenem, but now we are even seeing carbapenem resistant. Yes. So the WHO has divided this into critical, high, and medium as a guidance for the manufacturing companies, if they want to manufacture, they should consider this as one of the priority pathogens to target when they are manufacturing antibiotics. Next. Yeah, so at a country level in Kenya, we do not have the data yet on antimicrobial resistance, mostly because the surveillance is yet to be there. We're not doing enough surveillance because we're not ordering enough diagnostics, enough culture and sensitivity tests to get the data on antimicrobial resistance. But at a global level, it's a burden. And as we can see, around 700,000 people die every year because of resistant infection. And by 2050, this global estimates will be seeing about 10 million lives being lost in a year. And that is even more than things like cancer and cholera or even diabetes. Yeah, so we need to watch out for antimicrobial resistance. And when we talk about antimicrobial resistance, people usually feel like it's something that will happen in the future. But antimicrobial resistance is with us even now, because when you walk into any ward, any hospital, you won't miss out to find a patient who, if they've done a test, you would find they are resistant to a certain medication and they need to be using any other medication. So resistance is here with us. Yeah. Next slide. So let's look at how antimicrobial resistance affects patient health. So it does affect patient health in various ways. First, when you're looking at the cost of medication that we'll need to use as an alternative, it starts being expensive. Because when you start with simple drug medication like amoxicillin, flucloxacillin, which are your access antibiotic and your first line, when you compare these medication with drugs like meropenem, amoxicillin is very costly, but when you look at meropenem, the retail medication for one vial of meropenem is around 800, between 800 to 1200 shillings for one. And for a patient who's taking 1 gram 3 times daily, they will need two vials. If it's 500, they will need 2 vials multiplied by 3. So when they're buying it at the minimum cost of 800 shillings, multiply that by 2, that's 1,600, and then multiply that with times 3. So you see how expensive antimicrobial resistance is. So, and that is just medication for one day. This you will need to, the duration of that medication may go on for around 5 to 7 days or even 14 days. So imagine how much this patient will be spending on just medication alone, let alone just staying in the hospital and all the other hospital bills that they will need to cater for. So it's very costly. And even being available this medication is not easy, because you'd find patients buying, if they're not available at the hospital, they will buy for 2 days, they will miss for another 1 day, buy for another 1 day, miss. So it will be a very erratic way of giving this patient medication, and you'll get a lot of missed doses. We also would get delay in treatment, because most of these medications are not available at the hospital level because of the cost. And you'll have to sometimes send the patient outside to buy this medication. But before they even get the money to buy, that means the patient will have delayed, will have delayed the medication for these patients. We're also using more toxic agents, because when you compare the simple antimicrobial to some of these, like meropenem is nephrotoxic. Something like vancomycin is even nephrotoxic. So you have to renal adjust for some of the patient, and watch out for some of this renal toxicity. you'll end up using less efficacious medication in some cases, like multi-drug resistant TB, where when you're moving from, because first line is the most effective, but when you're forced to go to the second line, it's not as efficacious as your first line. When you're also looking at the clinical outcomes, most of the time you might get treatment failure. Patient will have prolonged hospital stay. They might end up getting admitted to the hospital or readmitted to the hospital or even in the ICU. So there are so many implications to the patient and even to the healthcare facility at large. And that's why we really need to watch out on these antimicrobial resistance. Next. So, and this is the reason as to why we need antimicrobial stewardship. Antimicrobial stewardship basically is multidisciplinary program advocating for and monitoring appropriate use of antimicrobial. More often than not, it has been misinterpreted to mean reducing the use of antimicrobials. That means that you are denying the patient antimicrobials. But this is not, we mean, what antimicrobial stewardship means is that if a patient needs a specific antimicrobial, they need to get it at the appropriate time, at the right duration, and even dose. So if a patient is in need of meropenem, they need to get meropenem. If they do not need to be on meropenem, they do not have to be on meropenem. Switch them to another agent. And we cannot talk about antimicrobial stewardship without talking about diagnostic stewardship, because these two are intertwined, but more often than not, diagnostic stewardship has been ignored because of lack of resources, but even lack of positive from the clinician in ordering some of these tests like culture and sensitivity. And when you look at the antimicrobial stewardship guidelines for 2024 or 2023, it also talks about lack of data because of lack of surveillance from the level 4 and level 5 facilities, mostly due to lack of resources, but even due to lack of the initiative from the clinician to push for culture and sensitivity tests to patients who needs them. So these two are intertwined. When a patient come in, you will need to have them diagnosed. And if it's something like sepsis, you'll need to get blood culture so that it can guide you, because what we are introducing, even if you're using a broad spectrum antibiotic, this is empiric coverage, but you essentially don't know what bacteria is causing the infection that you're treating. That's why you need a culture to help guide you so that you can have a targeted therapy. So with that, when you take a test for microbiology and interpret it, because a lot of the time also microbiology can misguide you such a way that when you get the test, the only thing you see is meropenem as the only drug that you're going to use, in as much as you might have other sensitive antibiotics. Yeah, so next. So the objective of antimicrobial stewardship is to reduce the inappropriate use of antimicrobials, thereby reducing antimicrobial resistance. But before you even talk about antimicrobial stewardship, you will start by identifying the problem, because you might think that you have a problem when it comes to the usage of antimicrobials, but you might probably they're using a lot of ceftriaxone but they're in compliance with the guidelines. So it's not just enough to say that in our hospital you're using a lot of ceftriaxone. You could be using a lot of ceftriaxone, but maybe it's because of they're compliant to the guidelines or because of availability is the only option. So you start by identifying the problem. And you would do this by looking at the data. Data is a very
Hello, Dr. Mevin. We have lost you for a bit there. We apologize for the technical error. we have lost Dr. Mevin. Mevin, if you can hear
Hi.
us. Okay, you're back, you're back.
Yeah, sorry about that. Yeah, so people, when you go in and tell people that you're using antimicrobial in the wrong way, it's not just enough, because you need to be backed up by the data, because you will be misguided by just looking at the general overview and you're seeing that a certain antibiotic is being overused in a certain area. You just need to go back and look at the data. And you might do this by using some of these tools like point prevalence survey. And these are free resources available on the website. There are two tools that you can use: the WHO or Global Point Prevalence Survey methodology in helping guide you to collect data on antimicrobial use. And this is good to do before and after the intervention so that you can monitor if there's any progress. Next. So some of the data that you can collect from point prevalence survey is patient level, like demographics, and then ward, so that you can identify which ward is not using the antimicrobials well, and then indication, so that you can compare that indication to the antibiotic that's used. Indication diagnosis goes hand in hand, and then antimicrobial use. From antimicrobial use, you will look at the name of the antimicrobial agent, because even writing it's written, when you're writing, it's not encouraged to write when you're prescribing, to write it in trade names. You need to use INN names. So name of the antimicrobial agent, the route of administration, duration and dose, and whether there's missed doses. So you need also to look at the treatment sheet and see whether there's missed doses. And then you need to compare whether it's compliant to the guidelines. Because when you just look at the data in isolation without comparing it, whether they're compliant to the guidelines, it will misguide you. And then it will also classify the medication according to access, watch, and reserve, so that you can know which medication is being overused or overconsumed, whether it's the reserve or watch or access, because WHO encourages that you should at least have more than 60% of the medication being from access. So if you see it's watch, you might try and go down and look at which category of watch antimicrobial is being overconsumed, and whether there's need for a behavior change. And then it also looks at the de-escalation plan, because once you introduce antibiotic, you need to review it after 48 to 72 hours, when the patient is clinically improving, to see whether they need to be switched from an IV to oral, or go for narrow-spectrum antimicrobial after you've received the culture sensitivity results. It also collects data on results from microbiological testing. Next. So this goes hand in hand with the data that you've collected, because that will help you see some of the common areas of intervention. Like if you're seeing a lot of broad spectrum antibiotic that's being used, or a necessary combination, or wrong antibiotic choice, or even wrong doses, or dose interval, or route, or duration. So this data you can easily collect from the point prevalence survey data. Next. So on top of this, you also collect data on documentation, which really helps, because indication, trade names, missed doses, these are some of the things, especially missed doses. This is missed doses is one of the things that we really noted when we were doing our point prevalence survey. And we really noted that a majority of patients get at least one in every, I think 10 patients would miss a dose, and for various reasons. So you can try and tackle these, and you can do this by looking at the treatment sheet of the patient, and also indication in the notes, because when an antibiotic is being introduced, you need to have the indication in the notes, but most clinicians miss out on writing the indication on the notes. And then You can pick out the culture and sensitivity test utilization, because we noticed this was also a bit low in our facility at the time when we were first collecting. And then you can pick the data on whether a great majority of the patients in the wards are on targeted or empiric therapy. And then you can also check, intervene IV to orals, which I think we've mentioned before. Next. So when you're implementing the antimicrobial stewardship intervention, you need to plan yourself well, and you can apply this PDSA cycle, which is really, really useful. But here you also need to study before, and you collect the data before and even after, and then you plan yourself where you will need to go on and make a change, and then implement it, and then study it again. The cycle keeps continuing. For you to also, when you're after you've collected the data before implementing any intervention, you need to have a goal, because it's not just enough to say you want to increase antimicrobial stewardship and to push for behavior change, but you need to be specific on the outcome that you want to get at the end of the day. It can be as simple as increasing IV to oral switch of metronidazole, something as simple as that. But you need to first look at the problem, if there's a problem at all, and then work on that goal, and make sure that it's measurable so that you can see whether you're improving or there's no change. And you need to also notice, for behavior change to be there, you'll need to apply this combi model, because you need all the three: capability, motivation, and opportunity, for clinician to have behavior change. If you need behavior change, capability is basically the knowledge, because there's usually a knowledge gap when it comes to antimicrobial stewardship intervention. And it's not just enough to go and say, we're using a lot of intravenous antibiotic, so you need to decrease the amount of intravenous antibiotics that you're using and increase oral. You need to be specific, because they will not know which oral to switch to. It varies from between patient to patient, from infection to infection. If it's urinary tract infection, patient has been on ceftriaxone intravenous and they're improving, they're responding well, they can be switched to something like another third gen oral, or another oral like ciprofloxacin, instead of continuing on intravenous. But it varies from infection to infection, and that's why there needs to be that capability. They need to know what to change to, and then there needs to be that motivation, and it can be motivating a good behavior, and then there needs to be that opportunity for change. Next. So some of the intervention that you can look at is educating the healthcare workers. In general, antimicrobial stewardship, because there's a lot of knowledge gap. And it's not just enough to talk to the healthcare workers, because you need multiple stakeholders, even including the administrators. Because from our end, like Kilifi, we noticed that the reason as to why we are not utilizing enough culture and sensitivity tests or microbiologists, because we do not have that capacity. And that's why we've been lobbying, and our efforts are starting to bear some fruits. And that's why all stakeholders need to be involved, like the administrative position, even at the county level. So you need to lobby everywhere by educating these people. And then also training the healthcare workers. And it needs to be specific topics, because when we were doing an assessment before some of these CMEs, we noticed that from one of the questions, most of these were interns. Most of the interns say that the reason as to why they would go for broad spectrum is because they do not know how to diagnose, and so because of lack of, they are not sure where to go to, they will just run with ceftriaxone because they think it's the safest option, quote unquote. So it needs to be specific, like targeting specific condition, like like you can just go for common condition like urinary tract infection or upper or lower respiratory tract infection, pneumonia, and things like that. And then documentation. Also, drug administration is one of the things that people ignore it a lot, because when you talk about surgical prophylaxis, it needs to be before the incision. But more often than not, if you're not keen, and I challenge you to just go, if you work in the hospital setup, find out when or how the pre-op medication is being given. We notice because of cefazolin is the recommended medication, but most hospitals do not have it, and therefore they go with ceftriaxone. And because ceftriaxone, when given as a bolus, would induce nausea and vomiting, anesthetists mostly will try and run away from giving it as a bolus or slow infusion, and give it as a and run it as an infusion throughout the surgery. So the incision has started, the operation, the surgeon is done with the, up to the time the surgeon is done with the surgery, and that's when the infusion that was running runs out. And this is actually now not even pre-op, it now becomes intra-op. And when you talk about surgical prophylaxis, it needs to be pre-op, at least 30 minutes to 1 hour before the incision. But most often it's given as an infusion in the theater. And this is one of the things that we're trying to address as a hospital by talking to the anesthetist, the theater nurse, and the surgeon on administration of this surgical prophylaxis. And then develop the treatment protocols, because it will guide them. And then looking at the review of antimicrobials 48 72 hours. These can be clinician-led, or this can be during the antimicrobial stewardship board rounds, which is, it needs to be multidisciplinary with a physician or an ID physician, infectious disease physician, and a pharmacist, and a microbiologist, and a nurse. So it needs to be multidisciplinary. And some of the things that you're looking at are patient on broad spectrum antimicrobial, but you can just pick a specific area. It doesn't have to be a wider area, or you can look at intravenous to oral switch, but don't give yourself pressure to look at the multiple areas. Just start with one. Yes, next. Sorry about these slides, but one of the things that I mentioned here is looking at infection prevention measures for patients who have infectious disease like tuberculosis, and MRSA is one of the resistant bacteria. Patients who have this, they need to be isolated because it's contagious. Also looking at consistent supply of medication, and even looking at the storage of medication. Also improving microbiology services and regular surveillance. Then you can also look at pre-authorization of reserve antibiotics, because this is what you have. And in the next slide, we are going to look at the form how that form looks like. And then you can also do automatic stop orders if you have antimicrobial stewardship review forms. Next slide. So this is what our pre-authorization form look like. And this is basically mostly for reserve antibiotic. And when I talk about reserve, is the last resort medication. And this would be meropenem and vancomycin for our setup. We do not have any colistin, so our reserve is vancomycin and meropenem. So before anyone is started on this, they need to fill this form, and it needs to be reviewed by a pharmacist and an antimicrobial stewardship physician. And then this form is reviewed after 48 to 72 hours, because we need anyone on reserve to have been done for culture and sensitivity, so that we can either de-escalate to a narrow spectrum or escalate to a much broader priority. Yeah, so next. WHO classify antimicrobials into access, watch, and reserve. And access is most of the time your first line, because they are a bit narrow spectrum and they have lower resistance potential. An example of this is amoxicillin, metronidazole, flucloxacillin. The next option is watch. Watch is much broader, and they also use as sometimes as first line and second line, but they have a higher potential for resistance. An example of watch antibiotic is ciprofloxacin and levofloxacin. Reserve are your last resort medication to treat multi-drug resistant, like the carbapenem. These are last category that's mostly not used, but it's not recommended antibiotics, and these are fixed dose combinations that are not necessary. Next. So when you're streamlining the therapy of patient, when a patient first comes, they will be put, most of the time they will put on broad spectrum therapy because for empiric coverage to cover for multiple antimicrobials, but you need a lab. You need to do a culture sensitivity test and then other evidence. And then once you get the report from the culture sensitivity, you go for a narrow spectrum or either change the antibiotic altogether or go broader. And you can, at this point, you can also discontinue or change from IV to oral. Next. So the goals of streamlining antimicrobial use is to reduce resistance, adverse effect, because as you've seen, the reserve antibiotics or these antibiotics that we use as the last resort have a lot of adverse effects. Yes, and they are very costly. So as I've also mentioned, we also look at the point prevalence survey can act as an audit tool, and this most of the time is usually a retrospective, but prospective audits can be done through antimicrobial stewardship in real time, antimicrobial stewardship rounds, or joining the major ward rounds during the clinician ward rounds. Yeah, and then giving your feedback on the use of antimicrobials. Next. Next. Oh, sorry. So yeah, IV to oral switch, as I've mentioned. There's a criteria that can help you consider switching from IV to oral. And this is when you're reviewing the patient's therapy 48 to 72 hours after they've been started on the antimicrobials. Move to the next slide. So we usually use the ACED criteria, and the ACED criteria talks about the A is afebrile for more than 24 hours. C is clinically improving, and then E is eating and drinking, and then D is not, the patient is not suffering from a deep-seated infection. So this is a criteria that can help you if a patient if you're seeing all these in a patient, then you're able to switch from IV to orals. But this does not apply to all patients because there are some patients that needs to be on IV for a longer time. So this varies from patient to patient, from infection to infection. And some of the exceptions are in the next slide. Next slide. So something like a liver abscess or osteomyelitis, because it's deep-seated, and infective endocarditis or even meningitis, because these are infection, you need a good concentration of some of this medication in the deep-seated, you will need to continue intravenous therapy. So it varies from patient to patient. Yeah. So this is mainly my last slide, but it needs to be a multidisciplinary for you to look at, for you to give an intervention. It needs to be multidisciplinary, and you need to involve the clinicians on ground so that it doesn't look like you're invading them or auditing them. You need to just work together with them. Also, it's not just talking to the healthcare workers alone. You also need to involve the administrators, both the hospital level, the management level, and the county level, because all these are involved. Because when you're talking about the supply of medication, For government facilities, we know there's that what that usually come through the county warehouse. And if, for example, Kilifi, because we are able to order directly from using our hospital's fund directly from meds, you will have other hospital around that are supplied by the medication that are coming from the county warehouse. And if they're not on board, you'll find some differences. You'd find that as Kilifi, we are using maybe cefazolin as a pre-op antibiotic, but the other hospitals around would be using ceftriaxone. But if you're in harmony, we're able to push as one voice in multiple hospitals and talk to the administrative and tell them that look, we need cefazolin as a antibiotic of choice for prophylaxis, just as an example. So it's really it needs to involve multiple stakeholders. Don't just look narrowly at the narrow bit of the healthcare workers. So the very last slide, got the very last slide. Yes, so these are some of my references, and the prescribing companion app is one of, you can download it. You can just search on about it and then download it, because it have so many resources, including online courses. And one of the online courses that you can look at is WHO toolkit for antimicrobial stewardship. It really has good information on antimicrobial stewardship. Yes. Thank you for listening.
Thank you so much, Dr. Shahada, for taking us through that session. We have so many questions that have come in during your presentation, but we will have Marcel present, then we'll have a Q&A session, and you'll be able to respond.
Thank you so much for giving me the time. Maybe someone may help us to share the presentation.
Yes, Marcel, welcome. Your presentation is coming up.
Okay. Thank you so much. My name is Marcel Ishimwe. I'm the founder and executive director of MLI Initiative Rwanda. So within this presentation, I will share you my informed perspective on community-based interventions, factors leading to spread of MLI in communities, and how best healthcare professionals can lead to public health intervention to curb the spread of this silent pandemic in the communities. Moving on. So before we move on, MLI Initiative Rwanda, let me first introduce you to MLI Initiative Rwanda. It's a youth-led non-governmental organization dedicated to combat antimicrobial resistance in Rwanda by promoting the responsible use of antimicrobials in both human, animal, and environmental sectors. But also we work to promote research related to MLR, and also we work to implement the appropriate infection prevention and control measures in our country, nationwide. Moving on. Moving on. Move on to the next slide. Okay, yes, we envision a Rwanda where antimicrobial drugs are used responsibly, ensuring access to use of quality, safe, and effective antimicrobials in the treatment and prevention of infectious diseases in both human, animal, and environment. But we've empowered the youth at the forefront of this transformation trend as we are a youth-led organization. Moving on to the next slide. Yes, within this discussion, I will introduce you to what is MLR, the MLR burden, MLR and One Health, efforts in the press to combat this silent pandemic, but also the role of healthcare professionals in tackling this silent pandemic. Moving on. Move on. move on the next slide. So MLR in brief occurs when bacteria, microorganisms like bacteria, viruses, fungi, and parasites no longer respond to antimicrobial medicines. When you say these antimicrobial medicine, we say antibiotics that target bacteria, we say antivirals that target viruses, antifungals that target fungal, but also antiparasitics that help to prevent parasitic infection. So let us continue in the next slide on the mechanisms of resistance. Next slide. Yes, I will like to introduce you the mechanism of resistance. So we have said like antibiotic resistance or antimicrobial resistance in general occurs when those microorganisms evolve to survive exposure to antimicrobials that are designed to kill them or inhibit their growth. So let us dive into the primary mechanism by which different microorganisms such as bacteria achieve to do that resistance. Firstly, it's enzymatic degradation or modification. By this mechanism, bacteria produce enzymes that can inactivate antibiotics. For example, we can take example of B-lactamase enzyme. So this B-lactamase enzyme degrades B-lactamase antibiotics, for example, penicillin. So the second one is about alternation of target sites. Within this mechanism, bacteria alter the antibiotics target site, preventing the drug from binding effectively. This also causes bacteria not to respond to the antibiotics that are designed to kill or inhibit their growth. For example, we can take on these mechanisms about methicillin-resistant Staphylococcus aureus, where there is alternation of penicillin binding proteins. Also, it can have the mutation in binding gyrase or topoisomerase, which prevent the quinoline from binding. So the third mechanism about ephylax pumps. By this mechanism, bacteria ephylax pumps to expel antibiotics out of the cell, reducing the intracellular concentration. Example you can take here, it's about the tetracycline resistance, where ephylax pump remove the drug from bacterial cells. Another mechanism about reduced permeability. As we have said, let's take example of microorganism, which is bacteria. These bacteria decrease the permeability of the cell wall or membrane, which prevent the antimicrobial drugs, antibiotics, from entering the cell wall. Example we can take is about gram-negative bacteria. These gram-negative bacteria alter porin channels to restrict entry of B-lactamase or carbapenems. Another mechanism is about bypass of metabolic pathway. By this mechanism, bacteria develop alternative pathways to bypass the inhibited step in their metabolism. We have also biofilm formation. By this mechanism, bacteria in the biofilms are embedded in a protective matrix, reducing the antibiotic penetration and enhancing survival. Another mechanism is about horizontal gene transfer, HGT, where bacteria acquire resistance genes from other bacteria. They can acquire these resistant genes from those bacteria by conjugation, transformation, and but also by transduction. Yes, let us go to the next slide. Move on the next slide. Yes, thank you. Here, we're going to explain contributing factors or factors that leads to the spread of MRSA. As you can see, we have different factors that contribute to the spread of MRSA in our communities. We have inadequate infection prevention and control measures, I mean IPC measures, shortage of lab diagnostic facilities, inappropriate antibiotics prescribing, over prescribing of broad spectrums, and misuse and overuse of antimicrobials or such as antibiotics. Yes, we have poor sanitation, poor quality of antibiotics. That's why we need R&D or research and development to develop different antibiotics or antimicrobials that can be used to treat these infections. So these are mainly the factors that lead to the spread of MLR in our communities. We may go to the next slide to see the impact of MLR on the global scale. Moving on, the next slide. As we all know, MLR is a silent pandemic. WHO and other partners have projected that in 2030, it will force up to 24 million people into extreme poverty if nothing is done. If we do something to curb this spread, the people will not be forced to reach now to this number. So, but if there is no action that is taken from now, the MLR will reach to 24 million people goes into extreme poverty. If nothing is done, also it is projected that in 2050, 10 million people will die annually on the global scale. So we are seeing that we have a great work. We have work to do to curb this silent pandemic from increasing. Moving on the next slide. So drug-resistant infections are now a leading cause of deaths worldwide. We are seeing that both breast cancer or cancer and malaria combined, they are leading the cause of death on the global scale. Yes, this screen is not showing the second screen. Maybe I'm not seeing the second screen. The second screen. Okay. Both HIV and AIDS.
Marcel, we lost you
cause of
for
death
a bit.
worldwide. But
Okay. You're back.
are you hearing me well?
Yes, yes.
Okay, thank you. So the MRR is the major leading cause of death worldwide. As you can see, both combined HIV and AIDS and malaria cannot exceed the deaths that are caused by the MRR. So we have a work to do to curb this silent pandemic. Let us move on the next slide to see the impact of or negative impact of MLR on the community. As you can see, MLR increases morbidity and mortality of people around the globe. As we have said, if nothing is done, we have said that 10 million people will die annually in 2050. So we have a tough work to do to curb the spread of this MLR in the community. We have also the treatment failures. If the people are misusing the antibiotics and the other antimicrobials, there is resistance will occur. If the resistance occur, there will be treatment failures, which will require people to do research and develop other antimicrobials to be used to treat those who are facing the treatment failures. Have also failing medical procedures and increased healthcare costs. If people are not being treated by the antimicrobials, for example, antibiotics, which have been designed to kill those bacteria or other microorganisms, they will the people will remain in the hospital, increase the hospital stays. So if these people are staying in the hospital, there will be also increased healthcare cost. This will lead people or families to get into the extreme poverty, as we have said. Uh, uh, as we have said, the 24 million people will go into extreme poverty if nothing is done by 2030. So let us move on the next slide. So tackling MLR requires multi-sectoral collaboration, aiming from the human sector, environmental sector, and animal sector. So we need a One Health approach to curb the spread of this MLR, because if we put efforts in one sector, leaving another sector, there will be transmission of diseases from one sector to another, as we are going to see it on the next slide. Moving on. Yes, as we can see here, we have different disease transmission chain. You can see like there are some diseases that can be spread from between animals and humans, including via food, including the diseases that can be spread via food. So these are called diseases that can be spread from animals to humans, that are called zoonotic diseases. So that means if we want to curb the spread of this silent pandemic in our communities, we need to prioritize the intervention that can be used to prevent the spread of this resistant microorganisms, superbugs, from animals, but also in human sector. If we put our efforts in one sector, I may say like we are doing zero work. So we need to put efforts from all the sectors, I mean, environmental sectors, human sector and animal sector, to make sure that we are curbing the spread of these drug-resistant pathogens in an effective way. So let us go to the next slide of global MRI response. As we can see, there is different activities that have been done to curb the spread of these resistant pathogens. As you can see, there is the global action plan on MLR, endorsed by the WHO Assembly, member states, and this encouraged different countries to develop national action plan on this MLR or NAP MLR. So we have also a MLR multi-partner trust fund, which also aspire to take a One Health approach to dispersing funds to support countries in their national action plan. Within this help, countries are being favored to curb the spread of this MLR in their communities. Yes, let's move on the next slide. There is different ways to curb the spread of this MLR or this silent pandemic. We need to develop and implement intervention that will reduce the unnecessary use of antimicrobials. You cannot do this in one sector. As I have said, you need to use One Health approach. You need to set those interventions that reduce the unnecessary use of antimicrobials in both animal, human, and environmental sectors. This intervention will lead to the reduction on the use of those antimicrobials and reduce also the spread of this MLR. Need also to limit transmission of infections by setting up different IPC measures or interventions in different sectors. You cannot focus on human sector, leaving the animal sector. These interventions need to be set in both human, animal, and agricultural sector or environmental sector. We also need to develop new treatments for infectious disease. Here we are talking about R&D or research and development. Within this way, to help us to reduce the spread of that drug-resistant pathogen or superbugs in our communities. Yes, in Rwanda, moving on the next slide, we are having moving on the next slide, activities or that have been done to empower communities and healthcare professionals in curbing the spread of this MRSA. As you can see here, we have Oasis Antimicrobial Stewardship Program. This is a certified program where people can go and take course to be equipped with the knowledge and skills that are needed to curb this MRSA. Yes. So this course is designed by the organization that is called Oasis Health. It helps people from Rwanda, but also other people around the globe, mainly in Africa, to get the knowledge and skills that are needed to curb the spread of this MRSA. So there is our role as not only healthcare providers, but also the community, our communities in combating this MRSA. We have said what contributes to the spread of MRSA in our communities. So let us dive in. What is our role as people in different communities to combat MRSA? Because if we curb the MRSA in one country, the people in another country may face the problem because there is flow of people from different regions to another. If people are having drug-resistant pathogens and are moving to another country, they may cause the people from
Marcel, we
why we
lost you
need
there. You're back.
yes
You're back.
that's why we need to equip the communities to also know what they can do to curb the spread of this MRSA. So moving on to the next slide, we have our role in curbing MRSA. If you are a patient or another person going to the healthcare to take medicines, remember to ask your healthcare providers how to take medications. How do you suppose to take medication? If you don't ask the healthcare provider, you will take you will misuse or overuse those medication, and that's the main the contributing factor to the rise of those drug-resistant pathogens or superbugs. Also, we are advised to respect all medical advices from your healthcare professional or provider. Never share medicines because if you're sharing medicine if you are sharing medicines, that means you have not got the proper diagnosis. So if you are sharing medicine with other people, there will be also misuse and overuse or misuse of those antimicrobials. That's why you don't need to take medicines from another people, because you need to go and visit the healthcare provider and do proper diagnosis for you, and look for the medicine that can be used to treat your disease effectively. We also need to practice proper hand and food hygiene, because if we don't do this, we will favor the transmission of these superbugs from one place to another or from one people to another. We also to do protected sex to prevent the spread of this. But because if you are not doing that, if you are not doing protected sex, there may be transmission of these drug-resistant pathogens from one people to another. We also need to respect the vaccination calendar. I mean, this goes to the people who are in charge of children's. We need to respect vaccination calendar not only for the children but also for other people. If you are not respecting the vaccination calendar, it also contribute to the spread of all rise of drug-resistant pathogens within the people who have not took vaccination or on the respected vaccination calendar. That's why we need to do these activities in a proper and effective way. So thank you so much. Thank you so much for attending. Are you hearing me, Juliet?
Yes, Marcel, we can hear you.
Yes, I may say like this is the end of my presentation. Thank you for attending. I look forward to a continued discussion. Thank you.
Thank you so much, Marcel, for that enlightening presentation. We do have some questions for you, but before we get to the Q&A session, we have Dr. Dorothy Aywak, Head of Pharmacovigilance at Kenyatta National Hospital. She's joining us and she's going to do a quick demonstration for us. Then we can have the Q&A session. We would like to apologize. We might be a little bit over our time, but we ask of you to actually pardon us for this moment. So with that, Dr. Dorothy Aywak, if you're able to hear me, this is your moment. Karibu sana daktari.
Thank you. Thank you very much. And as promised, I'll try to be quick, but I hope I'm going to be able to communicate. So just as a brief, the prescribing companion is a resource that is supposed to support AMS work, antimicrobial stewardship, in terms of being able to make it very easy for you to, as a healthcare worker, to access guidelines, not only related to AMS, but other guidelines that can help you access your treatment guidelines. So the prescribing companion is a project that is Fleming funded and is run by the Commonwealth Pharmacists Association. So you have 13 countries within the Commonwealth which have all signed up so that we can be able to have our guidelines within this resource. So we can if you just on your browser, if you do www.prescribingcompanion.com, you should be able to get a window like this. So I'll just request that we scroll to Kenya to just have an idea how we can use this for those practicing in Kenya. So when you get to the Kenya app, you find within the guideline, the resource for every country, you have this what we call the nodes. So there are 6 nodes which have divided the resources. So the first one has infectious and infectious disease prescribing. Then there's the other common clinical conditions. Then you have international stewardship and IPC resources. You can have an intervention recording form for those as you are doing the AMS rounds. You can be able to utilize this tool and you can customize it. And remember, with AMS, we are dealing with that One Health, and I'm glad all our presenters have mentioned that we can't ignore any aspect. So even the animal health guidelines will be loaded here. Then there's another tab that was modified. Initially, it was COVID, but now that COVID is not as much of an issue now, what we found is that with this tab, we now have other national resources. What does not fit in these other lines? So if I can just start with the infectious and infectious disease prescribing. So for Kenya, this is where we are going to host our AMS guidelines. They were just recently launched on Monday. And so I'm awaiting the soft copy so that you can now find these guidelines signposted here. But now what you do is when you need like now guidelines, just looking at guidelines for TB. A number of times when we're looking for guidelines, we are asking ourselves in WhatsApp groups, in meetings, how do we get, who has a guideline for TB? Then you have to start looking for where to find it. So this is how you'll be able to open it. When you click on that guideline, you'll be able to get exactly the way the guideline looks like, and you can be able to quickly refer. If we go back to that other tab, and then we go back, you can also still get the HIV guidelines the same way. It will open on a new link. The beauty with this is that now you don't have to keep going back to the browser to homepage to find the guidelines. And you can download the guidelines. You've accessed them. You can download them onto your computer or your device, or you can just keep accessing them directly from the browser. So if I want us to go to the previous screen so that we can see what is in the other common clinical conditions. Yes. Now, in other common clinical conditions, you will find the guidelines for the basic pediatric protocols, the guidelines for sickle cell, for diabetes, and they open very easily within it opens in a new tab so that it becomes very easy for you to keep going back and looking for different resources. I'd like us to now go to the tab which has other national resources. So within other national resources, if you go right to the bottom, see, for those in Kenya, you'll be wondering where we were looking for a place where you can enhance access to the national formulary. So if you go to that tab, Essential Medicine List and Formulary. So it gives you an opportunity to be able to quickly access what is our current formulary. because that also is supports management. It gives you an idea what is recommended in terms of what antibiotics are listed there. You can be able to quickly pick that as a guide. Now, to be able to, I hope I'm not rushing you, but I know. We go back still to other national resource and show you the various tabs within the AMR to support AMR work. So you see the material is divided according to whether you want resources on AMR, you could be looking for resources on IPC or resources on AMS. So you just go and look for what specific resource are you looking for. I want to hope I'm clear. I hope I'm sorry, Mike, it's really raining. I'm hoping I am still audible. So you can
Yes,
confirm.
you are. Yes, you are.
So if we can go back and what Dr. Shahada had mentioned, you can also use this resource for capacity building in terms of getting resources to support how you get training material. And that you find it in the international AMS and IPC. So if you could go there. So if you go to the tab for CW, pack, tools and resources, you'll be able to have access to CPD material. So you'll be able to have access to CPD material. So there's a CPD platform, there's IPC resource, and as she had mentioned, if you go to the AMS toolkit, you'll be able to get a guidance of how you can be able to do. As she had described how you can be able to, you can get various guidelines for how you can be able to support your AMS program. So it's quite a rich resource. And the idea is to be able to almost like have a one-stop shop to be able to get different resources. And now being a global village, if you move to another Commonwealth country, instead of struggling to figure out how do you get resource to support your prescribing or what guides management in that particular country, you can just go with, if it's within the Commonwealth, you'll find the resource there. And I think it will help you with even portability or even just being able to understand when you're dealing with a client who is from another country. I know I've rushed through, but I want to hope that I was clear and able to demonstrate. So I encourage you, and also this, you can get this resource also on Google Play Store and the App Store. You just look for the prescribing companion, you can download it. And then now once you download it, there's a square button or something that looks like a burger. That's where you go and look for the toolkit for that you want to download. So the toolkit would be is the country. So the country will be called the country toolkit. So you look for Kenya, download the resource, and now you can be able to even have the resource right on your phone. So I'm hoping that it's going to be of use as we continue to educate and advocate for better responsible use of antimicrobials. Thank you.
Thank you so much, Dr. Dorothy Aywak. That was lovely. I didn't know about the prescribing companion, but right now I am enlightened. And I feel like I am speaking for so many people here who are really going to take advantage of that resource and get to using it so that it is beneficial to us and to our patients. Thank you so much for joining us. And in this session, I would quickly like to take a few questions, maybe 5. I can see we have some questions on the Q&A box and a few on the chat, but you'll allow me to take 5. So we have Jean, who is asking, what are the challenges that are currently being faced while implementing One Health approaches to address AMR in Rwanda? So this is very specific to Rwanda, and I would like Marcel, if you could take this question. What are the challenges that are currently being faced while implementing One Health approaches to address AMR in Rwanda? Okay. Marcel, if you're here with us, we would like you to take that question. But while we are waiting, we have another question, still from Jean. He's saying, from the research about antimicrobial resistance mechanisms, which one is the most common pathogenic bacteria? From the research about bacterial resistance mechanisms, which one is the most common pathogenic bacteria? Dr. Shahada, you could help us with this question.
Which one is the most common?
Pathogenic bacteria.
That is resistant.
Yes.
So there's a lot of resistance that have been seen recently on ESBL producing E. coli, and it's mostly E. coli is mostly the bacteria that we would find in the urinary tract infection. So this is one of the bacteria that has raised the eyebrows on because when you talk about ESBL is producing E. coli, it will be an E. coli that is resistant to cephalosporin, and this is our ceftriaxone, the one that we really like. So third generation cephalosporin, and your only remaining option would be meropenem, depending on where the target is. Because if you find it in the urinary tract infection, you have an other option that you can use. But if you find it at another site, like at an incision site, the only option that you can use at this point is a carbapenem. Yeah. So one that has raised a lot of eyebrows is also from the WHO priority list of pathogen that have gained resistance. One of them is the third generation cephalosporin resistance of enterobacterial, which E. coli under.
Thank you so much. I would like to take another question from Perry James. He's asking what steps can be taken to ensure equitable access to effective antibiotics in underserved communities. Usually these are those communities that most times they never get access to these antibiotics. But what measures can we take?
It's just cascading the level of care, because more often than not, we expect some of this medication to be at level 2 or level 3, because these are a group of healthcare facilities that misuse antibiotic a lot, because they'll just go with the option that's right in front of them. If nitrofurantoin is the only antibiotic that's in the facility, that's what they're going to use, be it pneumonia, be it anything, they're just going to use the option they have. So a clinician is looking at the point where you need to refer cases. From a community point of view, insisting on a prescription. Sorry. So when you're looking at the access, it's just trying to refer this patient to a level of care where they will be able to get this medication. And also, what we might try to do is increasing the supply at the hospital level, because the level 2 and level 3 facility, they would get it through the county supplies, because they cannot order directly to with KEMSA, but they can get it through the county supply. So ensuring that there's appropriate supply of medication. But you also need to lobby through the county pharmacist in this case, because if she does not know, she's not going to be able to supply. She's just going to supply what she's been supplying, because she's used to supplying those. So that's why advocacy really needs to happen at all levels, not just at the healthcare levels. Yeah.
Thank you. Maybe we can have the second last question. Is it necessary for HCPs to be trained in AMR programs to become AMR stewards?
Actually, tomorrow at Kilifi Hospital, you're going to be training community health promoters, because when their role was being when they were given these kits, they one of the things that was in the kit was antibiotics, and after several push, I've seen that recently it has been removed, but I think they really need to, because they really need to know what they're doing, and so that they know, because they've been placed there so that, because they're the best, they are very accessible to the community, but they really know when to refer some of these cases, and not just to issue whatever medication is in that kit. So yes, it's very necessary, and this is one of the things that you're going to be doing tomorrow. Advocacy to the CHPs. Yeah.
Thank you so much. So we'll take the last question from Kevin. He's asking, when a patient is resistant to certain classes of antibiotics, is it a one-time resistance, or after some period, maybe months or years, can they be sensitive again to the same antibiotics?
What we also need to know is that a person does not gain resistance. Like me as a person, I'm not going to gain any resistance.
Mhm.
So what gain resistance is the microbe that's causing that infection that's affecting your body. So once you have treated this infection that's being caused by a certain microbe, and it has cleared very well, in future when you get another infection, it doesn't have to be resistant, but you are more than likely to get affected by a resistant bug just because you had been disposed before. So you have a higher risk factor for getting a resistant bug, but it does not mean that all patients that have been had antimicrobial resistance, in future they're not going to be susceptible. Yeah.
Okay.
But
Thank you.
what we just yes.
Go ahead.
Yeah, just the take-home message is that we, as people, we do not gain resistance. What gains resistance is the microbe and not the person.
Thank you so much. Thank you so much, Dr. Shahada. And we have come to the end of our session today, but we would like for you to give us your feedback regarding this sensitization session this afternoon. I have had people who have joined who are also not healthcare professionals. They have had some strange terms. At least they have gotten to understand what AMR is. And when we are pushing for proper use of antibiotics, there is a reason to this. There is a reason. So it is the reason that we have to save lives. We have to preserve the current antibiotics that we have. Thank you, Dr. Mevin, because you made it so clear that there are not so much manufacturers or organizations that are manufacturing antibiotics right now. So with the current streams, the lines that we have of medicines, we need to preserve what we have right now and make sure that we are using them well. Before I came to APN, I would not want to admit this to the public, but I was also not aware that there are particular sicknesses that you should also not be taking antibiotics. But as a novice or as an ignorant person, I should say, I was not aware of this. And then you find that we are the contributors of this AMR. So right now that at least we have been enlightened, there has been an education, you have received knowledge, you have been sensitized, we know that we can use antibiotics well. So I'd like you to go to menti.com. We will be there for only 3 minutes. Just share your feedback with us. And as we are sharing our feedback, I would like to welcome, I'm hoping Marcel is still with us on the call so that our speakers can share their final remarks. Would like for Marcel to share his final remarks, Mevin, you as well, and would also like Dr. Dorothy Aywak to share her final remarks. It has been such an honor to have her join us in this session this afternoon. So I will start with Marcel. Marcel, if you're in the session, would like to welcome you to share your final remarks. All right. Dr. Mevin, would you like to go second?
Yeah, sure. So the theme for this year is Wow Week is educate, advocate, and act now. So that's the message I just want to return back to the audience, is that you need to educate. The information that you've gained today, it will bear no fruits if you stay with it. You just need to educate other people, and you need to also advocate, and you need to act now, even if it's something that does not concern you, because at our level, you're pharmacists, but we've been advocating for microbiology services until people keep wondering why we keep pushing for the lab side instead of pharmacy side. So advocate, educate, and act now.
Amazing. Thank you so much. Thank you so much. I will be posting and sharing the knowledge that I have received here today. Dr. Dorothy Aywak, we welcome you to share your final remarks.
Thank you. I just want to appreciate the opportunity to be able to share about this quite resource, and I hope it's going to be helpful. And in case you notice any changes or any challenges, then I just encourage the team to reach out. I think you can reach out to APN and they can be able to get that to me. But thank you so much for all those who stayed on to listen, and happy Wow Week.
Happy Wow Week. Happy Wow Week. Thank you so much. Thank you. Thank you so much. Our hearts are full of gratitude. We are saying thank you. I will be sharing the recording and all the presentations that we have had from Dr. Mevin and from Marcel with each and every one of you who have registered and been part of this session. We'll be having all those resources in your emails within the next 20 minutes, so you'll be able to revisit this. We'll be making the posts online, but I want to encourage you to continue participating, continue creating awareness about AMR, and make sure that we continue to fight for the future generations that will come. Thank you so much. I want to wish you all a lovely afternoon, a lovely evening, wherever you are. We'll be connecting again on Friday, and I want to hope that you have seen the post that we have shared. We will be having another session on Friday, same time, 4 p.m., and it will be on research and development efforts to contain AMR. And these are advances and opportunities to further research, and it is a specific case for drug-resistant TB and multi-drug-resistant TB. Our speakers will be from Cambridge, Dr. Elizabeth Kigondo and Dr. Robert Onsare. I am hoping that I will see each and every one of you. The link is on the chat. Get to registering and we will connect again on Friday. Thank you so much. May the good Lord bless you and enjoy the rest of your week. Goodbye.